Good evening, and welcome to AUA's The Latest Breakthroughs in Metastatic Hormone-Sensitive Prostate Cancer 2025 live virtual course. We strive to offer outstanding educational courses and greatly appreciate your evaluations and general feedback so that we can continuously improve our programs. The AUA is accredited by the ACCME and designates this live activity for a maximum of 1.5 AMA PRA Category 1 credits. Evaluations are very important to us. Course evaluations and CME credit will be administered electronically on AUA University immediately following the course. As we at the AUA continue to develop virtual education that meets your needs, we especially welcome your feedback regarding both the content and format following this program. All persons in a position to control the content of a CME activity are required to disclose to the AUA as the ACCME accredited provider all financial relationships with any ineligible company, formerly commercial interests, during the previous 24 months. An ineligible company is defined as one whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. The AUA must determine if the individual's relationships are relevant to the educational content and mitigate any conflicts of interest prior to the commencement of the educational activity. The intent of this disclosure is not to prevent individuals with relevant financial relationships from participating, but rather to provide learners with information so that they can make their own judgments. Coding advice given during presentations are the opinion of the presenters and may not have been vetted through the AUA for accuracy. Please verify accuracy prior to reporting on medical claims. You are prohibited from using or uploading content you accessed through this activity into external applications, bots, softwares, or websites, including those using artificial intelligence technologies and infrastructure, including deep learning, machine learning, and large language models and generative AI. The AUA would like to thank AstraZeneca and Bayer Healthcare Pharmaceuticals, Inc. for providing independent educational grants in support of this activity. Finally, I'd like to introduce and extend a special thank you to our course director, Dr. Sanaj Poonen, for his time, talent, and expertise in developing this program. Dr. Poonen is a board-certified urologic oncologist and full professor in the Desai Sethi Urology Institute at the University of Miami and Sylvester Comprehensive Cancer Center. He completed medical school at Queen's University and residency training in urology at the University of Toronto, Canada. He then went on to complete a fellowship in urologic oncology and master's in clinical research at the University of California, San Francisco. Dr. Poonen is the vice chair of research in the Desai Sethi Urology Institute, assistant director of the clinical research and co-lead of this cancer control research program at Sylvester Comprehensive Cancer Center, and a proud recipient of the Papcore Endowed Chair of Solid Tumor Research. I will now turn the course over to Dr. Poonen.
Thank you to the AUA for that introduction and for the opportunity to moderate this course, and also to thank you to the participants for giving their time this evening with us. Great. Thank you for everybody for participating in that. And as I mentioned, we'll get a second chance at these questions at the end of the webinar. So this was really a global needs assessment that was done by the AUA in advanced prostate cancer that really highlighted the need to provide more education to care provider teams around metastatic hormone-sensitive prostate cancer. And our learning objectives for this evening, as you can see, the 5 that are here, and we're going to go through each of these in a little more detail, but essentially we're going to talk a little bit about personalizing therapy in this space. We're going to talk about biomarkers and the role of biomarker testing in metastatic hormone-sensitive prostate cancer. We're going to talk about novel pathways, specifically this AKT pathway. And then we're going to finally finish off with a talk about multidisciplinary collaboration between the various providers that are involved in this space and strategies to manage and mitigate common adverse events that are associated with some of these medications. Now I want to introduce you to the rest of our panelists this evening, and we have an esteemed multidisciplinary team that I'm very happy to have join me because they all know a lot more than I do. So we're going to start. We have Pedro Barada, who's a medical oncologist from Universities Hospital, Seidman Cancer Center. We have Rachel Hastings, who's a physician assistant from NYU Langone. Paul Nugent, who's a radiation oncologist from Harvard Medical School, and Michael Williams, who's a urologic oncologist like myself from the University of Virginia. Perfect. And with that, we're going to go into our first area or topic, which is really on personalizing therapy in this space of de novo metastatic hormone-sensitive prostate cancer. And as many of you who may be as old or older than I am know, when we started off in this space many, many years ago, everyone was getting a very similar drug, an antagonist, an agonist, and if they failed that, then we had limited options. Today, as you can see on the slide here, there's several options as a first-line therapy, and having a little bit of flexibility in terms of how we personalize that is something that we're trying to talk about today. So, Pedro, if you don't mind, we'll start with you as a medical oncologist and does a lot of this. I mean, how often are you able to have some flexibility in personalizing therapy versus just giving guideline, appropriate treatment to everybody, and how do you do that?
Sure. No, thank you so much but by the way, thank you for having me. Great panel and a very, very important topic. And as you know, for a long time, we've been struggling really to, offer best standard of care to patients, right? So the number of folks not being offered treatment combination strategies, whether it's doublets or triplets, it's actually been quite significant, right? And just recently, we're now getting over 50%, which is encouraging, but we're not there yet. And the reason why we say that, because all we see here in this table, it basically demonstrates that when we do something in addition to suppressing testosterone, whether it's a form of an ARPI, an androgen receptor pathway inhibitor, or chemotherapy, or combination of all the above, we're able to improve overall survival in this meaningful way, very meaningful way, without compromising quality of life. So that's the first step. And so your question really is, so first of all, many are still not being offered the best standard of care available in 2025 for these patients. And then the next question then would be, when can we have some flexibility, right? What is the gray area here? So I would say we can think of the opposite. If we think of a spectrum, right? We can think of the folks that might not require as much down the line, and we can think of the patients where perhaps we're gonna kind of pull the trigger and throwing the sink at them because we understand the behavior of the disease won't be the same, right? So one example on the first situation would be a case of low volume disease. We're now defining limited amount of cancer sites of disease that we define based on PSMA PET, for example. And we call those oligometastatic disease. Let's just say a patient has, 3 bony spots, right? And there's this debate: should we keep these patients on long-term systemic therapy? And many of us would consider local therapy to the prostate gland, and we're talking about newly diagnosed metastatic disease. But then the question is, should we actually go ahead and treat those sites of metastasis that we can see with local therapy? And I'm sure our friend and a colleague, Paul Nguyen, will talk more about that. And I can tell you, I have a case, many cases like that, where I do tend to offer local therapy and ask the help from experts like Paul to help us in these situations. And in some situations, it's possible to achieve long remissions. And in many cases, patients are able to come off therapy for quite a good time, quite a good deal of time, right? And we in remission without progressive disease. So we need more data to validate that. But that's an example where sometimes we're pushing the envelope. If we think of the opposite scenario, same patient, 3, 4, let's say four bony lesions. However, 50-year-old, you end up doing genetic testing and is a BRCA2 patient. So BRCA is a prognostic marker. It predicts things not going in the right direction. So this is a patient where you may not have thought of triple therapy. You're in the limbo, right? If we were to have one more, then you would be talking high volume disease, one spot in the rib, 4 other spots in the spine. So this patient is one disease, one site, I guess, less for you to consider high volume the way we define it. I would argue in a BRCA positive patient, for example, where the aggressive of the disease the biology will play a role. This is a patient where I have discussed triple therapy with an individual like that because I wanted to cover the androgen component of the disease and the non-androgen dependent or not as much dependent disease given by HR positive. So it's again, we're talking about the gray area. And so from that perspective, as we understand the data, we understand not everybody should be treating exactly the same way, and we're getting steps in the right direction by bringing molecular characterization of the tumors and incorporating information we get from germline and somatic testing, in addition to, of course, timing of metastatic disease as well as volume of the disease, if you will.
Great. Paul, I'm going to come back to you in a second about radiation, as Pedro mentioned. But Michael, if you don't mind, I'm going to bring you in a little bit. Pedro talked about doublet therapy, triplet therapy, and really doublet is kind of when you're using two different medications that are targeting, the androgen receptor, and triplet is when you're bringing in chemo. I'd love to get your thoughts on when you're doing, or looking to treat patients with triple therapy versus doublet. And then Pedro also mentioned, conventional scans versus PSMA PET imaging, which, has kind of really, I don't want to say messed up the space, but made it very interesting in terms of how we quantify the volume of disease burden. So just to get your thoughts on those two.
So starting off with that last comment, I think that the most important thing everyone should know about these trials is that the vast majority of these trials were done in the CT and bone scan era. And so our ability to identify high volume disease then is very different than what it is now. PSMA is so much more sensitive. And so someone that would have been low volume 10 years ago is now actually high volume if you look at it in terms of small numbers of Mets. And so that can change kind of things. We really don't have any information or data that says, oh, yes, you should do this or you should do that. I think the key components is really just to understand that we're diagnosing it a lot earlier. And because we're diagnosing patients a lot earlier, we're actually able to kick the can a lot further down the road than what we had before. So Pedro's comment about even consideration for stopping or giving a treatment break or something along that line, though that's not what we traditionally would think of, is actually something that's very common for patients. Because quality of life, the frank reality of the situation now is that the vast majority of patients that get diagnosed with metastatic castrate-sensitive disease are alive 5 years down the road. And that is a remarkable thing for a stage 4 cancer in any way, shape, or form. And so we have to think of this as a chronic disease. And like hypertension, like diabetes, and all the different things that we actually bring to the table with our metabolic syndromes that we cause by the drugs that we give, I think all of those things have to be taken into account. With respect to whether or not I use, a triplet therapy or doublet therapy, kind of just depends on the patient that shows up in front of your door. If you have a high volume person that's young and healthy and an ECOG 0 and is jogging 5 miles a day all the time, it's real easy to pull the trigger on a triplet therapy. If you have someone that has a BRCA2 germline mutation, real easy to pull a triplet therapy on that. But someone that's frail and old and is maybe in their mid 80s and they just got diagnosed, this is not necessarily someone that we're trying to get to that next level or that 20-year down the road or 10-year down the road. It may just be to maintain pain control. And I think all of those things come into play here. It's not one significant finding that's going to tell me I have to do this or I have to do that. And I think it's the person right in front of you and what they want in terms of the goals of care.
Great. Paul, I want to get your thoughts on radiation. We talked a little bit about this space of oligometastatic, where you're not widespread metastasis and may just be a few sites or less than 5. And I don't know what this magic number is, but when you are part of these multidisciplinary clinics and you're thinking about the role of metastasis-directed therapy, how do you look at that in terms of, how many lesions is too many? Is there any flexibility in how you're targeting or doing your radiation dosing, things like that?
Yeah, definitely, Sinoj. And thanks so much for the invite here. I'm really excited to be here with this fantastic panel. We definitely do think about metastasis-directed therapy for these patients. And these trials, as Michael was saying, generally they were done with conventional imaging. And so now when you do PET scans, you see so many more spots. I think everyone feels pretty comfortable doing it for 3, 4. Once you start getting 5 and above, it starts getting a little bit more hairy. You get problems with insurance companies paying for these kinds of treatments. But we have pretty reasonable data from the COMET randomized trial, which looked at a whole bunch of different kinds of cancers and showed a benefit to radiating those metastases and doing metastasis-directed therapy. It was actually an overall survival benefit, although it was a phase 2 study and it was multiple tumor types, so I can't say it's really level 1 evidence yet. And we've got some nice data from the STOMP and the Oriole trials showing prolongation, especially from Oriole, of metastases doing metastasis-directed therapy. So I do like to think about it for anybody that's healthy, that's got 3, 4, 5 metastases. I think we should be thinking about SBRT for these patients, and it should be part of the armamentarium. But I recognize that we still need more level 1 evidence. Where we do have a lot of level 1 evidence, and where I don't want anyone to forget, for these oligometastatic patients, low volume disease, we've got a table up for those of you on the podcast. We've got a table up with the first line agents in metastatic hormone sensitive, and we got AbbVie, APA, Enza, Daro. But I want to remind everyone that radiation to the prostate has a hazard ratio for overall survival that's just as strong as any of these drugs. The hazard ratio was 0.64, so a 36% reduction in death from adding just one course of radiation, which is the same as what you get from abiraterone, apalutamide, enzalutamide, darolutamide. The question that we face now is everybody gets these other drugs, and so is radiation still valuable? I think for young, healthy patients, I do radiate the primary for these patients because I think, look, 2 different things show a survival benefit. They're not toxic. Why don't we just put them together? So that's how I think about it there. Of course, we've got the great study by Brian Chapin, fantastic urologist at MD Anderson, who's looking at this, looking at adding radiation or maybe adding surgery to patients who are already on abiraterone or best systemic therapy. So we'll see, and I do support that trial, but do want to remind everybody about the value of radiation for low volume metastatic disease.
Yep, actually, great point, Paul. Rachel, I know we have a lot of discussions around, first line therapy and which one we want to pick based on maybe pathways that we could target or synergistic response to medications. But in the real world, patients come in with their preferences and their goals and things that they're really seeking for in their care. How do you, as a first line person managing a lot of this, balance their quality of life issues, predeterminations about what they're willing to do and not willing to do versus, personalizing their care?
Yeah, thank you. I think when these patients come in, a lot of times their heads are spinning. It's a lot of information. It's a biopsy, it's a PET scan, it's blood tests, it's, bone scans, all these things. And so I think the first thing is just to assess their understanding of their current disease. Sometimes I really have to break it down and go all the way back to the beginning and say, where we are and what our plan is going forward. And then you really need to find out what their motivators are. Is it longevity? Is it gynecomastia? Is that they don't want any pain? Is it that they have an upcoming wedding to get to? If you can kind of align your goals with the patient early and find out what their motivators are, what they're willing to do, what they're willing, not to do, that just helps as you kind of go along with the discussion. And the one big thing I think is important is we always talk about shared decision making, but really important to get the family involved with that shared decision making. Whenever I walk in and a patient's sitting there alone, I'm like, who can we call on the phone? Who can we get in here for this discussion? Because sometimes they're just staring at you like a deer in headlights. So I like to have a family member or loved one involved, and that helps us understand what the goals are also. And then documentation, keeping all that down, for all the providers to know and share as we, see radiation oncologists, medical oncologists, urologists. So we're all on the same page on what the patient's expectations and goals are.
Awesome. Thank you. I think that will take us through our first segment, and I'm going to move to our next segment, which is going to be more about biomarker testing. And just a reminder as we get into this to our participants, we are able to monitor the chats, and if you have any questions, we'd love you to join the conversation and just throw it into the chat. So we're keeping a look for that as well. So as you can see on the slide here, and we don't have a lot of slides, this is probably the last one, I think, but we could see, various guidelines that are kind of showing here and what their attitude is toward testing. And I know it's a pretty comprehensive slide, but almost all of these guidelines are, unanimously advocating for testing in this space. And I think this is something that we are trying to do more of, and probably underutilized, to be honest. Michael, if you don't mind, I'm going to start with you. And I'd just love to get your thoughts as a person that probably sees these patients, at the very diagnosis to very late in the stage. What are your thoughts on the role of biomarking or testing, in the metastatic hormone sensitive space? When should we be doing this, and how are you even using it or acting on it, if you are at all?
So it's a great question. I think the complicating factor for most people to understand is that all of the drugs that we currently utilize for positive germline or somatic testing are drugs that are only given in CRPC M1. So at the next level, at the next phase. So you actually get this testing early. For me, we get the testing at the time of metastatic diagnosis. And germline is what we choose for that, and that goes along with a lot of counseling and stuff that goes with it. Obviously, a cancer history is no longer just a prostate cancer history; it's a cancer history within the family. Whether it's breast cancer for the BRCA1 and 2s, whether it's other things like Lynch that you actually kind of find throughout the way with colorectals. You always kind of want to get more of a comprehensive history, and that's something that many urologists have just not done for years and years and years. It's just not something that's high on their radar unless it's something that you're doing all the time. In general, what we'll do is we continue with germline testing at least normally if we don't get it within the initial time frame, because that's one of many things that we talk about whenever a patient walks in my door with metastatic disease. We'll get it within that second visit or third visit. And it just has something for documentation for later. It does help us if we think about triplet therapy or something along the lines. But nextly, for me, somatic testing comes whenever patients develop CRPC. We know that overall germline testing, probably in the 1 to 2% of the population will have these genetic alterations. But once you develop castrate resistance, you fail one of these primary therapies, that number can range anywhere from 15 to 25% along a board. And so you want to really find out whether that's fluid, with blood testing, or whether that's tissue testing for somatics. That's the basics that we want to get everyone to at least acknowledge. But you have to understand that none of these things are going to be acted on right away, except for it might flavor how you might want to treat in terms of a triplet or doublet therapy overall.
Great. Thanks, Michael. Pedro, anything different that you guys do? Anything that would be different in your workflow? And if you don't mind, what are some of the different, testing
Yeah.
options available?
Yeah, great question. So just a reminder for the audience, right? So we're talking about two types of testing: germline testing, genes you're born with; somatic testing at the tumor level. The challenge in the space of metastatic hormone sensitive, if you handle it, you should be seeing more recurrent metastatic hormone sensitive. You are seeing newly diagnosed metastatic disease. So that means as many of these patients got either biopsy and underwent definitive radiation hormones or radical prostatectomy many years ago. And so a lot of times, we see a lot of second opinions. Patients come to me, they already started hormones. So to Michael's point, as soon as patients start systemic therapies, it's difficult to find circulating free DNA. And you can do germline testing, but if your tissue is very old, you end up deciding on the somatic testing later on at time of CRPC. So the logistics around the testing are relevant. And the other piece I'd like to highlight to complement what has been said, which was spot on, remember the three reasons why we do it. We do it because there's a prognostic role, meaning we sit down with patients, we're able to educate and have a very thoughtful conversation about what might happen in the future, independent of treatments that are exposed. It has a predictive role, meaning it opens the door to options that otherwise we would not consider for those patients. And finally, has an impact in the family. We call that cascade testing. So if you find an alteration of interest that is running in the family, you're able to identify that family who's at risk. You're able to involve genetic counseling, and you do it while you have time. So those are really the reasons why we actually do this. Of course, we'll talk a little bit about it. I agree with Mark completely. It's not that we're treating completely different. There are a few exceptions. I mean, I think the future is going to change quite rapidly, I would say. HR or Almog's recommendation repair deficient, such as BRCA. We just saw data with niraparib, abiraterone. We'll be seeing new data soon with talazoparib, enzalutamide, etc., around PARP inhibitors in this setting. We will see soon also data with the AKT inhibitor for patients with PTEN alterations. So we are very, very close to have an impact. Some patients you'll find MSI high or mismatch repair 2-3% of the times. So you will see an impact in the treatment that in the near future. But from that perspective, you have the prognostic piece and the family piece that you can address, and you have thoughtful conversations in the clinic with these patients.
Thank you, Pedro. Thanks for adding that. Paul, so far, most of what Michael and Pedro were talking about is looking for, biomarkers that are going to tell them about medications that may target certain pathways. When you're giving your radiotherapy, are you aware, is there anything that you try to use or things that you're aware of coming down the pipeline maybe that can help there?
Yeah, here I have to give a lot of credit to Fu Tran's group. Fu started at Johns Hopkins, and he went to Maryland, and he just is now the chair of GU Radiation Oncology at MD Anderson. The radiation oncologist has done a lot of work in this area. So his group found two things, and it's about how these biomarkers influence the thought about giving local prostate therapy in metastatic disease as well as metastasis-directed therapy. So if you have these mutations, if you have the BRCA or the ATM and these kind of pathogenic mutations, then for sure you're going to do worse off. So prognostically, all of these patients are going to do worse off. But interestingly, those patients who have the mutations actually have more of an effect from the metastasis-directed therapy. So those patients need metastasis-directed therapy even more, according to his work. And then they looked at it for local therapy. And those patients who don't have the mutations are actually the ones that benefit more from local therapy to the prostate. So maybe the thinking there is, gosh, if these patients have all these mutations, their disease is so bad, it's so prognostically poor, and it's really the outcome is determined so much by systemic therapy that the local therapy doesn't matter as much. Whereas they don't have the mutations, and they benefit more from local therapy to the prostate. But it's kind of the opposite for metastasis-directed therapy, where if you have the mutations, you need the metastasis-directed therapy more. So it's kind of an interesting dichotomy. It's great work by Fu's team. And I'm just happy that we live in an era now where radiation oncologists actually integrate some of these biomarkers to think about radiation sensitivity.
Yeah, it's really cool how far we've come. It's very, a lot more science and methodology behind a lot of what we do. Rachel, I'd love to get your thoughts on this too, because this is, I think, a very confusing space for patients and providers, and it's changing rapidly, as we'll see in our next section. How do you counsel patients that are coming in to discuss, the biomarker testing and, all these different things like that? And I'm sure it's, how do you even keep up with all of it?
Yeah, I think with a lot of what I do is pre-education. So again, the patient comes in, they're like, what, their head is spinning. So kind of break it down exactly like what Dr. Barada said. So first, prognostic, why are we doing a test? What are we hoping it will, help us decide? Or for you specifically, talk about personalized medicine. Patients like the idea of personalized medicine. So explain to them how this kind of can align with that. Then the predictive factor, kind of bring that in and kind of break that down to terms that they can understand how it may change their treatment, or offer different treatments for them, and then the family history. And if it gets real complex down with that cascade testing, then we go our multidisciplinary team with the genetic counselors. They certainly help a lot with this for some of those patients. But again, it's just pre-education, helping them to understand. It may help guide certain things. It may not change much for them. But the percentage of patients that it does, it can have really valuable impacts. So just highlighting the fact that it's personalized medicine for them and break it down to terms that they can understand.
Great, thank you. And I'll just ask the rest of the panel if we have a little more time anyway before we finish this segment off, is when you're discussing a lot of these pathways or testing with patients, are you often incorporating the use of genetic counselors? Are you sending most of your patients there, or do you guys tend to do some of this on your own?
So that was actually something I was going to bring up. It's something I think that a lot of urologists fear, because I don't know if it's like y'all's area, but for us, we have a catchment area of about 2 million people, and we have a grand total of 3 genetic counselors for the entire realm, and 2 of those are really children, pediatric, genetic counselors. So all in all, that they're very hard to come by. what's really remarkable is how this has changed so much over the last 10 years. Before, we used to have to really seek out genetic counselors overall, and now practically every single positive test, you automatically get sent to a genetic counselor. Though it is sponsored by the company that they work with, it's still something that's offered. Are there still some questions? Of course. I mean, if you're getting counseling for germline stuff, this is stuff that affects your entire family. And those are the questions that come up about insurances, which health insurance can't be denied, but it doesn't mean it can't be increased in cost. Those are all questions that kind of come up along the way that families really have. And I think they're valid questions. And so some of the companies actually offer pre-germline screening counseling that I think is really important for those that are really worried about that. But just knowing, having at least a generalized basis for how you decide on when you're going to get genetic testing and why you're doing it and what the purpose is. Most patients, I think, are very, very motivated to understand that to help their outcome overall.
Great. Pedro, anything different?
Yeah, no, I agree completely. There are not enough genetic counselors, and I think during our training, probably most of us did not really learn a lot about it, right? So things change quite a bit, and there's actually one challenge or one barrier to genetic testing is how much knowledge, how comfortable are we dealing with those results, right? So we're talking about two things. We can involve genetic counseling in the beginning for the pre-test counseling, or we can involve genetic counseling afterwards, post-test counseling. But if you do it post-test counseling, someone needs to do the pre-test counseling. So someone needs to know and do it. And so I think it's a very institution-specific resources and whatever works for a site, that's fine as long as it's being done, right? But we do recognize that there's a knowledge gap that needs to be closed and breached, and and so some institutions have done it better. Resources are there. Others have figured out other ways, collaborations, etc. It is true that the companies have done a great job because they are now providing that services as part of the testing as well. And also, we're just talking germline for genetic counseling. Of course, we can go beyond that and just talk about somatic testing, and even go beyond DNA and go into RNA, protein, etc. So it is a complicated field, a very new field for many of us, and we do recognize the challenges that this field, this new area, brought to us, and that's close really with education.
Great. I think that's right on time for us to move into the next segment. So the next segment, what we wanted to talk about was going to be a little bit about, novel kind of pathways and things that are going on. And we're going to talk about this new P13 AKT pathway, which is really about a new pathway, something that we think may be targetable. But Pedro, I'd love if you could start us off and just tell us a little bit about this pathway. What do we know about it, and how it got discovered, and what we think we may see come from this? Oh, you're muted.
Thank you so much. Yeah, no, it's a fantastic question. And when you look at cell cycles, just kind of doing a trip back to our, biology classes and basically chemistry, perhaps, and physiology. But we have a number of signaling pathways, right, that take the cells to be able to thrive and grow and proliferate. PI3K AKT is one of them. There's others. We might have heard of RAS pathway, WNT pathway. Those are signaling pathways. So this one has been the focus of a lot of research in breast cancer, in prostate cancer, and for the most part, we understand the association between alterations in some of these components of the pathway, such as PTEN alterations and prognostic factors. So we know these patients do worse. Tumors behave aggressively, if you will. Actually, PTEN is one of the genomic alterations, which, by the way, is a tumor suppressor gene, but that actually is defining aggressive variant disease a little bit later on for mCRPC. But we actually been quite unsuccessful targeting this pathway as a way to improve outcomes of patients. We tried PI3K inhibitors, for example, but that might change, and I think it will change in the near future. In fact, we have AKT inhibitors, and the breast cancer field has been ahead of us. And we have a large study in the prostate arena, in the metastatic hormone sensitive space, where for the first time inhibiting this pathway through AKT inhibition is able to improve outcomes. We know that as part of a press release of a large studies called Capitello. And so I do believe that for the first time, we'll be able to, appreciate that. To be fair, another study in mCRPC, Joe and DeBono led those efforts, a few years ago. And we did see that for those alterations. We're just not, it's not the, as concerns about the trial design was not able to pen that out in an independent manner. However, I do think that what we've learned over time of what the role of this pathway in tumor growth and proliferation and the ability to inhibit it, perhaps AKT was probably going to be the next step as a way to target, or meaning treatment implications of our understanding of the important role of this pathway in cell growth and proliferation.
Great, thank you. Michael, when we had talked a little bit on the last section about, pathways and biomarker testing, you had alluded to the fact that a lot of these things are not going to be things you're going to necessarily do in the castrate-resistant first-line space. And obviously, we are talking something that's going to be more in this not castrate-sensitive space, but we're talking about something now that probably you're not even going to be thinking about until you're castrate-resistant. But I guess, if you don't mind, just tell me a little bit about how your thoughts are on the newer things that are kind of coming to the space and how you keep up with it, and what kind of research you need to see before you're saying you're going to introduce something into the clinic. And while we may not know whether this pathway is going to translate to something that we use in the hormone sensitive space, we do see a lot of these things start in the resistant space and then move up. So how do you, as best you can, kind of, prepare your patients when they come up with this thing that they read on Google that may not be something for them now, but how you kind of educate and navigate them through some of these things?
Sure. I mean, well, that's always nice to have people that have read stuff, but it's also obviously not really put on the right branch of the tree that they really need to be on. And that's always a challenge for most people. I think for most physicians, at least for where we're at, we're involved in a multitude of clinical trials. And so having this set up to where you actually look for stuff with germline mutations, you find a PTEN loss, that enrolls them into another trial that gets them on to something like this, where we end up finding out that, hey, it's not just inhibiting AKT, but it's actually the androgen receptor inhibition or the loss of androgen production that leads to this upregulation of this AKT, which then allows for the AKT inhibitor to actually work. Those are all things that really have developed over the last several years for us to really understand better. So I think all in all, like everything in medicine, and it's becoming more and more specific, as far as what you have enough capacity to learn on. If you're focused on it and you're doing it every single day, you've got to make part of that your research, just knowing what's out there and what's coming. And a lot of times, some of these trials are getting approved, just based off of phase 2 data, which is kind of surprising. That's not something we traditionally think of. But it's actually coming around in that way. And so you need to kind of be on that leading edge, at least have a general understanding of the pathways that are out there and what we're targeting and where we're seeing stuff. Because like he had just said, like Pedro had said, the large study was 1,000 patients. It had a 2.5-month improvement in radiographic progression-free survival, not necessarily overall survival, but it was there. So it's just showing you the hints that these things do move the needle a little bit more. And in a disease at CRPC, where things go very, very quickly now, kind of like what we used to think 15, 20 years ago when CRPC was diagnosed and we didn't have any other therapies, but Taxotere, it's nice to see that that new things can come out that actually can change that needle dramatically.
Great. Thank you very much, Michael. Rachel, I'm going to go to you before I go to Paul on this one. Similar question, I'm sure you get a lot of patients that are going to come in and highlighting some trial in maybe a completely different space and then asking you whether there's, a role for that. How do you navigate a lot of that, with patients that, may be looking for something that may be more targetable, or some study that they found that may not apply to them, but they're looking for this novel agent and the data doesn't really apply at that point?
Yeah, I think sometimes you have two extremes. You have the patients that come in with all the research and all, and none of that's going to apply to them at all. And then the patients that it will apply to are like, no, I don't want to do anything new, anything investigational. So that conversation can be a little tricky. Again, just kind of taking it back to the basics and explaining where they are in their disease, what we've done, what we haven't done, and kind of like what you said at the beginning, the very beginning of the talk, we started out with just ADT kind of, and now we have all these other agents. So sort of breaking it down and highlighting what's relevant to them and what's not. But yeah, sometimes getting that gap to close is the hardest part of my day.
I can imagine. Paul, a couple questions for you. You know, in the last segment, you had highlighted, you know, the role of some of these biomarkers and some of the work that's been done showing how it can play a role in terms of response to either metastasis-directed therapy or even primary therapy to the prostate. So one question for you is, one, how are you aware of anything with this particular pathway or any of the signal pathways like that? And then the second question, I think, which actually maybe even more important, you know, when we're talking about somatic testing, you know, a lot of times what we're talking is someone that's tested the prostate, right? That's the majority of the times where it comes from, as you know, and many others obviously on this call, that may be very early on in the whole patient's, you know, spectrum. And if you were to actually get a metastasis, you know, directed biopsy, you're going to get something that may be much more unique to the situation they're in, prior therapies they've had, and probably, you know, a panel of biomarkers more specific to what you're going to treat. And hearing what you were saying about the response, you know, that you get based on that, what are your thoughts on should we be doing more of this versus, you know, just, you know, liquid biopsies and stuff like that, which may not necessarily give you that kind of robust information?
Yeah, it's such a great question. I mean, so much of the data is from the tissue we have. It's from tissue banks. It's from what we already have. So we already have that somatic tissue. We've got plenty of it. And those are the easiest studies to do. And so, you know, the data that I've been talking about, that's where we get this information from. And that's ultimately what we know for the moment. And we have to hope that the the somatic tissue at the time of prostatectomy recapitulates whatever's going on in the metastasis, but we also know that that's not always the case. And of course, I'd love to hear more from others on their thought about that. But I think that's where we're at now, and hopefully we can get to a point where we know more specifically about the metastasis and how to treat that. I would say with the PI3, you know, an AKT pathway, we certainly have preclinical data that makes us think, wow, these patients might be more resistant to radiation. But I would say we don't really have the clinical data yet. You know, we don't really have clinical data on what do you do? Is an inhibitor of AKT going to help with this so-called radioresistance? And does this radioresistance happen clinically? I would say we have, it's not ready for prime time yet. It's not something we incorporate into our day-to-day, even though there's preclinical evidence that might suggest it.
Right. And I'll to Pedro and Michael, you know, the comment on, you know, getting biopsies from the metastatic sites as opposed to just relying on the prostate, especially if patients have gone through, you know, many different lines of therapy since, let's say, their prostatectomy. What are your thoughts on that? And share, you know, what are your patients' thoughts on that too, I guess.
Sure. Yeah, I think Paul summarized it very nicely. I don't think we know enough to exactly, you know, describe what happens over time, right? There's some, you know, publications, some fantastic efforts about serial biopsies and kind of see, you know, do you acquire them over time or what happens? For example, HR, you know, we do know for the most part they're truncal, right? And the other thing that you run into is if you do it with different methodology, you also increase the chances that you might have not seen it previously because the method was not good, right? Versus using the same method over and over again, and which implies that the quality of the storage of the tissue needs to be present, right? If you want to do something serial. So it is challenging. And you know, and the other one is what are you talking about? Are you talking about genetic sequencing of the gene, or are you really talking about at the protein level by IHC? You know, so and so for example, I can tell you some of, you know, for specifically for PTEN, we're, you know, and around the AKT inhibitors, for example, we're really talking about AHC based assay versus NGS. And so what's going to happen is we're going to start getting reports where, in addition to what happened to the gene, we also going to have IHC as part of the order that we put in, and we get that information. So it's very complex. It's not an easy answer. It's not easy to biopsy these patients. A lot of sites deal with the issue around decalcification around bone biopsies, which is the common site of metastasis for these patients. Not everybody is willing to go through a repeated biopsy. We do it more for things like visceral disease, liver mets, for example. You know, but in fact, we don't have enough. With that said, for metastatic hormone sensitive, we are quoting up to a third of the patients or something like that, having those alterations of interest. But again, it depends on the series you're looking at.
Great. Thank you guys very much. So I think we're going to go into the next section, which is actually the one I'm most excited about, really looking at multidisciplinary collaboration. And again, to all our participants, we do have the chat open and everyone is here to take questions. So please engage and send any questions you have. And I think, just speaking to the fact that we have all these different providers here just to have a conversation about, metastatic prostate cancer really tells us how multidisciplinary it is. And I think it's really unique, the fact that we are all practicing in different institutions and somewhat different practice settings. So actually my plan, if you don't mind, was going to be just going through everybody and asking, how are you practicing multidisciplinary care at your institution? How do you do it? How do you share between the medical oncologist, radiation oncologist, urologist, and NPs, PAs? And then anything that you think could be done a little bit better, or you'd like to see more. And Michael, I'll start with you since you're at my top right.
So very different setup practice-wise. We're at Eastern Virginia Medical School in Norfolk, Virginia, and our group is actually a private group called Urology of Virginia. We have 25 physicians and 34 APPs throughout the practice, and we cover 90 to 95% of the catchment area of 2 million people. Interestingly, we also have a medical oncology group that is also a private group, and they capture about 80 to 85% of all the people in that area. Within their group, they have 4 GU medical oncologists, and one of the leading guys within the thought leaders, I guess, within writing guidelines and stuff, which is really nice for me to have. It makes my bladder cancer stuff really easy and makes my prostate cancer stuff really easy too. And it all depends on everyone's level of expertise. One of the things I kind of really like to emphasize to urologists just starting is that this is a field that you really can't dabble in. This is something you just kind of have to learn. It doesn't mean you can't do it. It's just that you've got to learn how much you want to do and how much you're going to refer and when you're going to refer. There's always conversations in private groups about adding medical oncologists to the team versus continuing to have a collaboration with others. And unlike a university setting for us, we're talking about radiation oncology that's in a different segment, medical oncology, different segment, urologists that are in a different segment, that, you sometimes end up with 5 different tax IDs that are all trying to treat the same people. So doing a multidisciplinary clinic in the same spot is not going to work. But that doesn't mean it can't work. I think that the biggest thing that the two of us have learned over the years, it's all about communication. And the one thing that patients love the most is to see me sit there and text him about what's going on and what the next steps might be and what trial he may have open that I don't have. And they love that collaboration. And they also love to see us give each other jabs back and forth, because he went Sloan Kettering and I went to Anderson. So we all have a lot of fun with that. But I think that's the most important thing, that though it's a difficult disease, it's something that can be done very well, and it doesn't have to be in the next room or all in the same room or anything along those lines. It actually, the way clinics are these days, it's just impossible to have that happen for most of us. So, but you can make it happen. It just requires work. And that's what I'd say.
Great answer. Pedro, how about for you?
Yeah, I love that answer. I mean, in addition to, we also structure that way, radiation oncology. So nuclear medicine playing an emerging role, right, in the GU space and prostate cancer in particular, the genetic team, but then also the ancillary support addressing all the components of quality of life, psychosocial support, dietitian around diet, right? Patients are very much aware, integrative oncology as well. So those resources are available. We are not physically at the same time, at the same place as Michael alluded to, but there's physical constraints and limitations. But I agree. I think what they want to see is we are able to bring in the people that are needed at each time. And the needs for patients are different, right? Their priorities, what they need at each time, are different, and we need to appreciate those. And that means we need to talk about them and ask about them, and then bring the people that we need to bring in. So whoever manages the disease, there's usually one quarterback, or one captain, I guess, and their job is to coordinating the care and bring into the ship, I guess, or into the game, the teams are needed at each time. Sometimes interventional pain doctor, etc. So depending where you work, you might find them within your institution, or nothing wrong if you have to go across the street to see that team. I think patients appreciate that we make that happen. In other words, we have the resources for you, and the things about institutions where you have it, etc. I think are perhaps less important, as long as we are working for him. We bring the teams important for the patient.
Great. How about you, Paul?
Yeah, I've had a kind of a personal journey because I work in actually two different settings in the Boston area, and they have two different setups. So in one setting, we have, and they're both academic settings. We have medical oncologists, radiation oncologists, and urologists meeting patients sequentially. So we'll be in different rooms, different times, sometimes different days. We try to get on the same day if we can, but often, it doesn't quite work out. So you're seeing people sequentially. And of course, you try to communicate, you text, you email, and we try our best to have some kind of coordination there. And then another system that I work in where all three walk into the room at the exact same time with the patient. And for me as a provider, this was very different. I mean, all of a sudden, I would think that I would say the exact same thing both times, but honestly, it's a little bit different when you have the urologist standing right in front of you, and you're not, you got to be a little careful about what you say about surgery and really say it, make sure that those numbers would hold up to a urologist. You can't just talk about erectile dysfunction is going to be this percent and that, and urinary incontinence is going to be this. You got to really think about it. And I think that's great. I think it's good for me as a provider to have to have another provider in front of me to be really accountable to. And I find the patients like it because they feel like, wow, these people are really, they're thinking about my plan together. But I understand that kind of model is hard to do. But for me, it was kind of eye-opening to see that kind of model.
Yeah, it definitely sounds like that, and I can appreciate that would be very difficult to do. I know we've tried to do things like that, and as you guys have mentioned, it just hasn't worked for various reasons. Rachel, how about you?
Yeah, I'm going to pull off a little bit of what everybody said already. I think what Dr. Williams was saying, communication is probably one of the most important parts of the multidisciplinary team. And as an APP, as a PA, I do find that it's a little bit harder for me. You guys went to medical school together, or you did a fellowship, or you can text somebody. And for me, sometimes it's there, but it's a little bit different. So when I initially see the patient, I really do try to set up those, doors of communication, reach out to the radiation oncologist, make sure that I want them to chat me, with anything, that I'm open to that back and forth communication. And that's, like I said, a little harder, but we're working on that. Dr. Barada talked a little bit about the team. I work in New York, so if you walk in any direction, you're going to trip over a radiation oncologist, a medical oncologist. So there's a lot of people, and some are within my institution and some are, outside the institution. Obviously, communication is easier within the institution. But I do like to bring up to the patient that multidisciplinary team involves them, the patient, and they're probably the most important person. And they really have to be an advocate for themselves and kind of going from one specialist to the other, since we're not all in the same room at the same time. So really empowering themselves with taking on what they can take on and then bringing the rest to us. And then Dr. Nguyen talked about accountability, and that kind of leads right into that. I think sometimes the patient needs to say, oh, well, so-and-so told me this and you're telling me this. So kind of keeping that line open and making everyone accountable, keeping the patient as, like I said, I think the most important part of that multidisciplinary team.
Yeah, great. Well, thank you guys for your answers. Those are really well thought out and great. Through this webinar, we've talked a little bit about, clinical trials here and there. And I think, as we all know, in the space of cancer, clinical trials is not just research, it's actually care, and then maybe that is not as much in hormone sensitive prostate cancer, but most of us are also doing hormone resistant prostate cancer. And I think clinical trials is a huge space there. And I think a lot of times when we are having these multidisciplinary discussions, there's a great opportunity, to help navigate patients into clinical trials appropriately, things like that. And I know everyone in this group is playing a big role there and feels that it's an important thing. So I'd love to just hear each of you say a little thoughts on how you think we could do that better. There's real importance to get more people onto clinical trials, more people that are not normally on clinical trials onto clinical trials, so we can learn a lot more how these treatments work in diverse populations and the biomarker data that presents with. So love to get your thoughts on how we could do a better job, getting people on trials for those that are appropriately needed for them.
One of the things that we started doing just within our region, just knowing what trials are already up within your region.
Yeah.
There's a lot of, in the days of old, there's a lot of institutional back and forth. No, you're taking my patient for this trial. No, I don't want that. And there's just really no place for any of that anymore. I think there's a lot of people that are much more interested in the collaboration. And so one of the things we kind of started doing is we just kind of went and asked, to this major medical oncology group, to our urology group, to one of the other major universities just up the road, short hour distance, just within the region, what trials we have available for these patients that they can functionally get to in a day and back without too much of a problem, and that's different, going to be different for different places. In New York, it might be that you have 2 or 3 hospitals within a few blocks of each other, and that's what you're going to focus on. Whereas other places, it may be within a region that covers 2 or 3 hours. So I think just having the knowledge base of what's there and updating it and having the collaboration and the conversations, but you have to be willing to have those talks and discussion. You can't be this is my department, this is what we do, and we don't do anything else. You really have to be out there doing other things and really getting involved. And for me, GU ASCO is a major item for that collaboration. I love that conference because it's run by medical oncology for the vast majority, and you have radiation oncologists, you have urologic oncologists, but it also gives me a different perspective on how you might approach something along the way. And that's important to kind of get people enrolled in what they need to be.
Great. Pedro, how about you?
Yeah. So the story around trials is a very complex one because there's a lot of factors that play a role. You cannot be successful with a trials program if you don't have champions. You really need people who believe in them. And then, but there's many factors. First of all, you need to understand your First of all, you don't learn this in your training for the most part. Building a portfolio is very difficult to do because there's a lot of factors that play into it. Like biologically, is that what you want to make sense? Is that the most, what do you think? You're betting on the future, right? You bring in trials, you're going to be treating patients with the future, so you hope, standard of care, right? So you're offering the future today. So that's how I see it. So you always, there's always many options in each setting. So the question is, which study are you going to bring in? Are you going to bring that study because there's involvement of the institution? You're bringing that study because scientifically is what makes the most sense? Or are there any other reasons for that? Or is there any competing studies that you're going to bring in? Do you have a population for it? Like what is going on in the region, as Michael alluded to, and then does it make sense? Can you open? Do you have the resources to open? So there's a lot that goes into it, right? We all talk about clinical trials for the right reasons, but we are, I think there's a lot of room for improvement from that perspective. I have to give, shout out to 2 things. One, we cannot really run a lot of the studies without the help of sponsors, and that's pharma sponsors. There's a win-win situation there. And so it's okay to take advantage from them because we're bringing a trial as an opportunity for patients. And if the trial doesn't fit them anymore, then we move on. But I do recognize their effort because, in fact, they do a lot of it. They do a heavyweight lifting there. Also, the cooperative group studies, the cooperative groups in general, many questions would not have been answered it wasn't for the cooperative groups work, right? There are questions that cannot be answered outside the academic environment, a pure academic environment. So I do believe those players, pharma on one end, cooperative groups on the other end, and allowing us to all get together and come up with the studies that we believe make the most sense to conduct and to see what happens there. And again, so that we can bring the future to today to our patients. But it's a challenging conversation, and it takes a lot to get to be really, really good. It starts with having champions who really believe in them.
Yeah, agree with you. Paul, how about you?
Yeah, I love Pedro's comments. I definitely want to second that. I totally support cooperative groups and pharma support, and hope that we continue to have that kind of support as we move forward in this kind of funding environment. And I think patients with these advanced cancers want to go on trials. They ask about trials. They come for trials, and yet even like at our NCCN cancer centers, it's maybe 15% of patients go on trials nationwide. 1 to 3% of patients go on trials. So really, the barrier is us, and we all know clinic is busy. We know it takes a long time to consent patients. When I'm running late in a clinic and it's like, oh my gosh, I could consent this patient. I know they're eligible, but it's going to be another 40 minutes. I'm going to be 45 minutes behind now. That's hard. And so, that's on us to try to figure out how to do that better. And that's why Pedro's talking about being a champion. When I'm excited about a trial, I can put tons and tons of patients on. If I'm not as excited, I'm not sure that I'm going to go that extra, mile and be late in clinic. And there are other things that we can do to make it easier. Sometimes we've had our research assistants pre-screen patients and kind of scan and figure out who might be eligible. And then they send us an email before, hey, don't forget about this trial. This person's eligible for this, this, and this. That definitely boosts enrollment, because then I start to think about it ahead of time. I might pull the consent ahead of time. I might, set up the visit in that way. So there are definitely things we can do on the margin, but I think overall patients are interested, and it's really, on us to figure out the logistics of how we can make that happen.
Great, thank you. How about you, Rachel? I know in terms of when you talk to patients, do you get a lot of interest from them in terms of getting them on to clinical trials or not as interested in clinical trials? How has the experience navigating them towards it been?
Yeah, it's really hit or miss. I think someone that's had a lot of treatments, been with the disease for a while, is a little bit more open to trials. Or in New York, probably more patients than in my previous practice outside of New York, because they just come in more educated or they're searching for things on their own. I think resources is a big thing. Having people excited and involved, and you do need those resources. So, involving our research nurses help a lot, and any kind of pre-work, pre-leg work, and then communication amongst ourselves. Coming back from conferences, or if you can't go, try to, see the highlights, especially as an APP. If your colleagues did go, to kind of chat with them after, and so you can learn what's new, what's upcoming, because these patients will sometimes bring me stuff and I'm like, oh, I don't know yet. So just keeping that communication open with your whole team, all the APPs, the other colleagues that you work with, med-oncs, urologists, all together.
Right. I want to thank you guys for your answer there, because as providers in this space, I know that's very important to us, but it's also very important to the AUA. They have a lot of education and awareness around the topic. So I think it was well received, your comments by everybody. As we go into our final segment of the evening, number 5, which we're going to be talking about managing and mitigating some of the more common side effects, so gone are the days where you give someone a Lupron shot and then see you in 3 months. With all these new medications out, that's a lot more packet inserts to read about and a lot more, things to navigate. So, Pedro, I'll start with you. When you think about the common side effects, that you deal with in this space, and I guess we could start off more to the drugs that are in the MS, metastatic sensitive space before we think about PARP inhibitors and stuff like that. But we'll have a little comment on that too.
Sure.
Go ahead.
In general, right?
Yeah, in general.
So sure. So beyond ADT, so availability today includes ARPIs. So you have CYP17 inhibitor, abiraterone acetate, which urologists have learned a long time ago that the safety profile is not as good as the anti-androgens. Hyperkalemia, potential liver dysfunction, the use of steroid for potential adrenal insufficiency, etc. So I think they got way smarter than us because med-oncs tend to use a lot more abiraterone than urologists. Then you have these 3 amides, if you will, enzalutamide, apalutamide, and darolutamide. They have a little bit of different safety profiles, if you will. Whether or not there's completely related to penetrance of the CNS, it appears so, particularly for darolutamide. It's irrelevant to keep in mind drug-drug interactions. Important to keep in mind some will give you rash, thyroid alterations, mental fogginess, and fatigue, right? In this case, it appears that darolutamide has perhaps the most favorable safety profile from that perspective. And I said that because it appears also that in general, the anti-androgens have about equivalent activity, right? And then we can debate the details around, the efficacy compared to abiraterone. But then you have chemotherapy. In general, here we're talking really about taxane, docetaxel-based chemo. It's really well known, microtubule inhibitor, neuropathy, fatigue, cytopenias are known with this therapy, which is IV. And then, we'll see the future, right? We just saw data recently with niraparib in combination. Niraparib is a PARP inhibitor. Of course, there's a number of potential side effects that go with that, including GI alterations, fatigue, cytopenias, even thrombotic events that are a possibility as well, and we might have other PARPs in the future. And then we're talking about AKT inhibitors in the past, right? And we'll see what happens to capivasertib, which has been explored here in the Capital 281. And that's a drug that actually general medical oncologists have a lot more experience than GU oncologists, because we don't really have experience with AKT inhibitors beyond clinical trials, right? But the general oncologists do, because they have those therapies available for breast cancer. And I think Michael alluded in the past, so far, I think all the approvals are in combination, to his point about overexpression of that pathway. And so we're talking again about GI alterations, fatigue, hyperglycemias, so those are real. So to your point, what are we going to do with them? It's a question. I think there's a learning curve, including PARPs, by the way. I should have said that. General oncologists have more experience with PARP inhibitors than GU oncologists do have. And the buzz around the GU in the GU field is higher than actually the use of PARP inhibitors by our community. So I think there's definitely a learning curve. Dosing, schedule, do you do dose breaks or not, or treatment breaks or not? But in general, these are the class of therapies that we're talking today. And in the near future, I should also include radioligand therapy, right? With PSMA addition there, with lutetium PSMA, which has a completely different MOA and also safety profile. But I think for the most part, people don't get too scared about it. We'll see some cytopenias, long-term toxicity. We'll see how that looks like. But, xerostomia and stuff. So different mechanism of action. We are alert for it. I think of all that I mentioned, probably most of us were very, very, very comfortable with the RPIs. I think many of us are comfortable with taxane-based chemo. And I think we're going to learn more about PARPs and AKT inhibitors.
Great. Michael, I know as a urologist, also in a different practice environment, how is it for you? I mean, are there certain things you don't try to do because of side effects, or you're still doing everything? And is it any different?
I would say, again, it goes back to how you kind of got brought up. I mean, when I was at Anderson as a fellow, the second someone went on hormonal therapy, they went over to medical oncology side, right? And we never did anything beyond this. It wasn't until I got into practice where my mentor, Paul Shellhammer, got me involved with doing Provenge, which we've been delivering at our practice and trials since 1996, and kind of went on from there. And, all the approvals went on with the Abbeys and the Enzas and apalutamide along the way, and it just kind of built on itself. So for me, it's kind of been neat because my entire time we've gone from just Taxotere to 20 different drugs that are out there. It's pretty impressive. That being said, it takes some time to understand what those side effects are. It's not something that just happens overnight. A lot of it, we've kind of developed protocols within our department. We only have, we have 5 people, 6 people within our cancer department that will do this or treat patients with this. And so, and they're all urologists. Most, we have 3 uro-oncs, and then we have a smattering of other minimally invasive guys that are doing oncology as well. And so all of us are involved with it. And it's not that it's unique to one, genre or another. You just have to know what's there. With abiraterone, I can still remember the days when I was trying to bring that back to the practice and everyone was flipping out about 5 milligrams of prednisone, like we were just going to give them a whopping dose of steroids and everyone's fascia was going to fall apart or something. It was always kind of a funny thing. I mean, those are just fears that everyone has when they first get started. Now we're talking about PARPs where 20% of patients are going to need a transfusion, when they're given this stuff. And so it's a totally different kind of mechanism. And I think you grow as time goes on. This is about 25% of my practice is just nothing to do with surgery for prostate, but all the medical management of advanced prostate. And though we don't do docetaxel, or cabazitaxel, we do everything else, including lutetium, within the practice. And so it has its own development. And like it was mentioned before by both Paul and Pedro, it's all about champions. People kind of really go after stuff that they really like. And if you find those people that enjoy that, and maybe they're not so interested in surgery, or maybe they're at their end of their career. These were conversations that we had at the time. My mindset was always the younger people need to be involved, because honestly, they're going to be the ones that are going to develop the next thing. And for us, even thinking about this concept of theranostics now, where we're looking at, PSMA is one portion of a PET, but soon there's going to be a renal one that's out that's going to be approved. And there's not very far behind that, there's going to be a lutetium type of renal treatment as well. So there's a lot of expansion in this field, and it's very exciting, but it's also, if you're not used to it, can be very overwhelming. So just starting off with just protocols is probably the best thing. I think Abby's one of the ones that I like to tell people, when we first get started, it's a BMP or CMP every 2 weeks for the first, 3 months or so. And then it's backed off to just every 3 months, whereas Xtandi or any of the other AR inhibitors, we're doing it just, every 3 months along the way. These are things urologists didn't see this. Urologists didn't even get a testosterone. None of us got testosterone because no one wanted to give Taxotere until they were like in full on pain. It was a completely different time. So it's really kind of unique. We've all gotten better and more comfortable over the last 15 years, and it's just very exciting. That's all I'll say.
Oh, that's great. Paul, I wanted to bring in radiation a little bit. I'm sure you've heard your fair share of anecdotes of radiation causing toxicity, but now we have some evidence that radiation can actually lower rates of toxicity. Why don't you, if you don't mind, just tell us a little bit about that?
Yeah, finally a win for radiation and toxicity. So, we knew as we started out this segment that for oligometastatic or low volume metastatic prostate cancer, radiating the prostate can improve overall survival. But it doesn't do that for high volume metastatic prostate cancer. But thanks to the PEACE-1 study, we actually learned that whether you have low volume or high volume metastatic prostate cancer, radiating the prostate does reduce the risk of serious long-term GU complications. And so, I do think about this for my patients now with high volume disease. If they come in with 10 or more metastases, or, I'll say, all right, we probably won't make you live any longer, but we could reduce the risk that you need a TURP in the future, or you go into urinary retention. And patients find that compelling. Now, I do have to be careful. I have to select my patients carefully. I don't want to cause terrible toxicity to reduce toxicity or reduce the risk of toxicity. So, I do try to be mindful about that. It's not the same as when you're improving overall survival. But yes, thank you, Sinoj, for giving me a chance to mention that.
Absolutely. Rachel, we want to get you in here because you're often the first one getting the call about side effects, and have probably more experience managing than any of us. So just love to get your thoughts as we close out this segment on, what you've heard so far, or anything that you do differently in mitigating this.
Yeah, I just think very simply, again, kind of pre-education and optimization. So approaching the patient as this is an opportunity for them to kind of take charge of things that they can control. So earlier in the disease, get that blood pressure in check, diet, exercise, all those things, get a program, get on it, make sure you have, cardiologists, people set up, and then helping them to understand sort of who's kind of driving the ship, or if you will, for what side effects may arise. So maybe educate them on what the potential side effects are so they can kind of self-monitor a little bit, and then really lay out what that follow-up, what their protocol is going to be like, how often they're going to be seeing you, how often they're going to be getting blood. So they have that expectation up front. And then obviously communicate any changes and identify any specific risk factors for them and intervene early. That's my 2 cents there.
I want to thank all of you for your time you've given this evening. I know we're going to close and have our post assessment wrap up, but before we do that, I've been very blessed to have all of your knowledge and experience collectively through this webinar, and so have all the participants that signed in this evening. So I want just to thank our panelists for just giving their time today. Great. So I want to thank all of our participants that have tuned in this evening to the webinar. I hope you all learned something and hope you found our conversation engaging. I want to let you know what the keyword so you can claim your CME credits for this is green pepper. And I want to thank again my panelists for giving their evening and time for this great discussion, and to all of you that have tuned in to learn something with us this evening. Thank you again.